like to invite up Dr. Roach Singh, Dr. Martin, Dr. Laird, and another member of our faculty that you haven't yet heard from, Darren Klaus, who is the Chief of Vascular Surgery at the David Grant Medical Center, Travis Air Force Base. We'll have a somewhat abbreviated discussion, but we'd like to address your questions primarily, make sure that the issues of the day have been addressed, and then we'll be breaking at 10 minutes till the hour. John, I've been asked to chair this session, but feel free to come up to the microphone and ask any questions.
I think maybe we'll make use of Willie too. Willie, why don't you come on up and join us up here. I think we have 4 chairs. So a number of people submitted questions over the course of the day, and some very good questions. Many of them were directed towards the speakers, but I think we can probably make use of our panel tonight to try and address some of these questions. And a few of the things were directed at the early talks in the day related to some of the medical therapies for PAD. So we'll pick the brain of some of our experts. And Willie, there was one question that was probably directed more towards you. And the question was, what is the best role for D-dimer testing? As a screen for DVT, for defining the duration of therapy, et cetera, et cetera. They made note that the cost of a D-dimer test at UC Davis is about $79, so maybe relatively cheap compared to the stuff that we do.
Yeah, I thought the first question was about the plastic surgery, but anyways, I'm going to answer this question. D-dimer has really been published extensively as a negative predictor for DVT and VTEs in general, meaning DVT plus PE. As far as the literature on risk assessment for recurrence of DVT, for those trials I showed you, including both from Shervastava, from Paul Riddick's group, as well as Pellegretti's group from Italy, there is still in the investigational stages. So if you were to look at most of the medicine society and consensus documentation, that the D-dimer is currently not being used or not clinically being used for that purpose. Now, however, like I said, the investigation is on stage. So right now, as the way it stands, that in the hospital setting or even in emergency setting, that D-dimer is primarily used for patients when you're first trying to rule out DVT, and that's been documented. That's actually part of the medicine consensus, and I think that the literature definitely, we have level 1A evidence suggesting that whether a positive or negative D-dimer is used for that purpose. But as far as risk assessment, I would say no. Now, and that's what I said that during my talk, that you may have more questions than answers after the talk, just because, you know, a lot of things that we still don't know. But for a $75 test and ruling out a DVT, so rather than going through extensive, repeat ultrasounds or even CTA or even pulmonary angiogram, I think D-dimer definitely has its place in the, not so much the diagnosis, but the rule out of VTEs.
Thanks, Willie. In his talk, Jeff Southard made the statement that statins increase walking distance in PAD patients. So you guys will be my factcheck.org here. What do you think about that, panelists? Is the data strong in that regard in terms of improved walking distance with statins?
Yeah, actually, Mark Krieger and Emil Moeller are the one that published that those particular studies using both Lipitor and there's also some data on simvastatin. So those are the two statin drug, atorvastatin and simvastatin being looked at in terms of improving claudication distance in a patient with intermittent claudication. Now, as far as treatment for claudication, obviously we know that there's only one drug that's out there, and that's Platal. But statin does have its efficacy and does have its role. I'm pretty sure that patient with PAD would definitely deserve a statin. Now, statin has pleiotropic effects, but based on Mark Krieger's and in Mel Muller's work that it does look like that there is some positive feedback with the statin in that particular population group. But as far as consensus documentation, meaning does SVS or SVM or ACC consensus being reported using statin as a treatment for increasing or improving distance walked, I don't think that we're quite there yet. I think that there's definitely more data that's needed before the different society could agree on that.
Thanks. So Christian, a question for you. This was again related to one of the early talks that Garrett gave. The question is, what are the data that guide antiplatelet and antithrombotic therapy for carotid artery stenting and lower extremity revascularization? Is there any data, or is it all just extrapolated from the PCI data?
Well, I think it's a very complex question. I mean, right now, obviously, in the United States, there is no Class 3 device approved for CLI below the knee. And while there's a lot of interest in the general concept that maintaining perfusion to the extremity with drug elution makes sense, the corollary is not true. Just because you do that does not mean that's going to relate necessarily to an improvement in either wound healing or salvage of an extremity. The problem why I believe there are no approved FDA devices is, if you can imagine the complexity and heterogeneity of the patient population and trying to show a statistically significant and clinically relevant improvement based on one intervention, that's very, very difficult. And so I'm chagrined to say that while all these companies are doing these trials OUS and then they're getting reviewed for US journals, I'm not saying that I'm not trying to suggest they're trying to drive off-label use, but I do think that unfortunately it's not going to be until we get drug-eluting balloons on the market and we start dealing with the concept that I was talking about of angiosomes and trying to really deal with the difficulty in opening up a total occlusion to a wound. Not until that happens are we going to be able to really show some differences. I do have a question, though, if you allow me.
Sure.
For Dr. Nota. I was back when I was a younger man. We were doing the traffic trial and the Adventist trial, and we know the results of the Talisman trial. We just had the results of the Tamaris trial, millions and millions and millions of dollars going after treating CLI, not necessarily in CLI Rutherford Class 6, but only 4 and 5. And it seems to me that it's difficult to understand why all of these trials are failing. Is it the wrong patient population? Is it the wrong mode of administration of the cell therapy or the gene or the protein, or is it all of the above? Because I'm waiting to have a miracle happen with what is being done with Juventus, with Aldogen, with the FDA is fast tracking these trials now, and it's exciting that these things are happening, but we've been waiting for decades and nothing has happened. What's the problem?
Well, is it on? Yeah. So for the protein therapies and the vector therapies, they don't move. They stay right where you put them. So they don't travel to the areas that it probably at most need. The stem cells will. There have been trials, there have been problems with the way that these stem cells are mass produced for some of these trials. That's not quite the way that we would do it. We wouldn't expand them quite that far out. We wouldn't, I'm going to get in trouble with Aldogen here, but we wouldn't sort the cells for 24 hours before we give them to the patients. So we need better production methods, and the patients, when the microenvironment is so far gone that the stem cells can't even live there. It's really hard. So it would be important to start these a little earlier, in my opinion, before it's the last-ditch effort. And most of what the FDA has allowed so far is really when conventional therapies have failed. So there are no kind of adjunct therapies going on right now that we would like to do. So many problems we're working on that we and so many others are working on them. Also, in my group, we do a hypoxic preconditioning of the cells before we put them in. When these cells are grown up in these huge masses, they're exposed to 21% oxygen while they're being grown up by all of the companies. And then you return them to this ischemic area that's 0.1%, and almost all of the cells just massively die. So we can see that in animal models. If you get them more preconditioned down to 1% before infusion, they do a lot better. They've upregulated the proteins that they need to deal with that microenvironment in such a damaged area. So we're learning from each trial, but I think each one's getting a little bit better.
Great, thanks, Jen. So one of the questions that just came up to the panel is, what are everyone's thoughts and opinions on treating below-the-knee disease and claudicants? Most of the older or the early angioplasty literature showed that for femoral popliteal angioplasty, long-term patency was worse if the below-knee runoff was poor. So thought being, if you can improve the below-knee runoff at the same time you're fixing the SFA lesion, perhaps the patient would do better or have better outcomes. Lou, any thoughts about, you've been around a long time doing this, do you treat infrapopliteal disease when you're fixing an SFA or popliteal lesion in a claudicant?
I don't know. I mean, what we've gone, the truth that we've held for years is that you just don't treat claudicants. Are we talking about short distance claudication or long distance claudication? I assume that we're talking about resistant claudication that doesn't respond to medication, that restricts either employment or activity to such a degree that the patient just can't go on existing. So there has to be a very, very severe reason to treat a claudicant, period. It's especially a problem, of course, with below knee. I'm not sure, at least it was in the past. I think that you can probably speak better to this than I can right now. We used to think of a small vessel as the SFA. But now you're treating vessels down toward the ankle, and really a lot of times those vessels seem to be better treated than some of the large vessels. So I'm going to have to let you answer the rest of the question.
Well, clearly people are doing it because, as Krishna alluded to earlier, a lot of the below-knee trials, including one of the atherectomy trials and stent trials, patients in those trials were Rutherford categories 2 and 3, so they got into these trials without critical limb ischemia. So people are doing it. Krishna, what are your thoughts? I mean, will you treat a tibial lesion when you're fixing the SFA in a claudicant?
Well, for me, I'm not evolving into a nihilist, but I truly believe less is more sometimes, particularly in claudicants. I think we many times dissociate a procedure from the continued exercise of a patient. I think a variety of physicians, including Mary McDermott at Northwestern, have made it clear to us that you cannot dissociate an endovascular therapy from the continuation of exercise. And so for me, I find it difficult in someone who's truly a claudicant, who has multi-level disease, obviously in the iliac, in the SFA, and may have a lesion in an anterior tib, to say I'm going to go after that. I'm asking, who am I helping? Am I helping the patient, or am I remunerating myself? Because I don't think we have a lot of an idea in that situation. I personally believe, although there's an evolving school of thought with some plus-minus literature from Italians who believe strongly that we should be going below the knee in claudicants to treat them. I don't know.
Let me ask Darren a related question. We'll finish up with this. Sort of the dogma over the years when treating the CLI patient was that you just needed to get straight line flow to the foot in at least one of the infrapopliteal arteries, through one of the infrapopliteal arteries. Some people now advocate a more aggressive approach, or basically you try and open up everything you can, whether it's a perineal, the anterior tibial, the posterior tibial, to achieve as much flow as possible and potentially protect that patient down the line if they get restenosis in one of the other arteries. Is that an approach that you buy into, or are you more of the traditionalist in terms of get one vessel open and that's good enough?
I think that's a great question. I tend to be more of the latter and try and get inline flow in one vessel. I think that there's a lot to be said that it's difficult to predict the hemodynamic result on an individual basis. And I think that when you treat one artery and see what the hemodynamic result is, and if you still have problems, or if there's still concern, you can come back and treat a second artery. I think that that's a pretty reasonable approach to it. I don't necessarily buy into trying to treat everything right up front at once. I think if you can get inline flow, see what kind of hemodynamic effect you get from that. What are you trying to accomplish? Are you trying to heal a 5 millimeter ulcer, or are you trying to save a TMA? And I think all those things matter. And so I think that it's not, you can't really create a dogma from a spectrum of clinical presentation.
Great. Well, unfortunately, we've run over time. Didn't get to many of the questions, but we'll try and hopefully spend a little bit more time tomorrow with some of your questions. So thanks, everybody, for hanging in there, and we'll see you in the morning.